If you're experiencing orgasms with little to no semen, you need to pay close attention right now. This is something many men notice but hesitate to talk about. You reach climax, you feel the familiar wave of pleasure, your erection is normal, everything seems to function the way it always has, and yet when you look down, there's little or nothing there. That moment can trigger confusion, anxiety, even fear. You may start wondering whether something serious is wrong with your body. Hello, gentlemen. I'm Dr. Mika Hayashi, a urologist with more than a decade of experience helping men navigate complex sexual health concerns. Today, we're talking about dry ejaculation, medically known as retrograde ejaculation. This is a condition in which you reach orgasm, but little or no semen comes out. If this has been happening to you, you're probably searching for answers, and you deserve clear, direct information. Dry ejaculation affects roughly 1 in 100 men in the general population. However, in men who have undergone certain types of prostate surgery, the numbers rise dramatically. In fact, up to 75% of men who have had specific prostate procedures experience this condition afterward. The important thing to understand immediately is that dry ejaculation is not painful. It does not interfere with your ability to get or maintain an erection. It does not eliminate the sensation of orgasm, but it can affect fertility, and it can carry a significant emotional impact. The reassuring news is that many cases are treatable, and even in situations where the condition cannot be reversed, there are still practical solutions available depending on your goals. Whether your concern is fathering a child or simply understanding what is happening inside your body, there are answers. Let's begin by explaining what is actually taking place physiologically. Under normal circumstances, when you orgasm, semen travels from the reproductive glands through the urethra and exits through the penis. On average, a man produces between half a teaspoon and a full teaspoon of semen during ejaculation, although this varies widely from person to person. The process is coordinated and depends on several muscles and nerves working in perfect timing. In retrograde ejaculation, that process is altered. Instead of moving forward and exiting the body, semen flows backward into the bladder. The key structure involved is a muscle located at the base of the bladder called the bladder neck sphincter. You can think of this muscle as a valve. During ejaculation, this valve normally closes tightly. Its job is to block the opening to the bladder so semen cannot enter it. When the valve closes properly, semen is directed forward through the urethra and out of the penis. If the bladder neck sphincter does not close the way it should, semen follows the path of least resistance. Instead of moving forward, it flows backward into the bladder. Once there, it mixes with urine and remains in the bladder until you urinate. That is why many men with retrograde ejaculation notice cloudy or milky urine the first time they urinate after orgasm. That cloudiness is semen that traveled into the bladder rather than out of the body. It's critical to understand what this condition does and does not affect. Retrograde ejaculation does not cause erectile dysfunction. It does not reduce sexual desire. It does not eliminate the sensation of orgasm. Most men report that climax feels physically the same. The primary physical difference is the absence or dramatic reduction of visible semen. However, fertility is directly affected. If sperm are traveling into the bladder instead of being ejaculated forward, they cannot reach a partner's uterus naturally. For men trying to conceive, this becomes a significant concern. I once treated a 54-year-old patient who came into my office extremely anxious. For 2 months, he had been experiencing dry orgasms and was convinced something serious was wrong. He had no pain, no erectile issues, but the sudden absence of semen alarmed him. After reviewing his medical history and running the appropriate tests, we identified the cause. He had recently started a new blood pressure medication. That medication was interfering with the function of his bladder neck muscle. We changed his prescription, and within a few weeks, his normal ejaculation returned. That case highlights something important. Understanding the mechanism is the first step toward a solution. When you know what's happening, fear begins to fade and you can approach the issue logically. Now let's discuss the most common causes of retrograde ejaculation, because identifying the cause determines what can be done. The first and most common reversible cause is medication. Several classes of drugs can relax the bladder neck muscle, preventing it from closing properly during ejaculation. Alpha blockers, which are commonly prescribed to treat enlarged prostate symptoms or high blood pressure, are well-known contributors. Medications such as tamsulosin, alfuzosin, and silodosin are frequent culprits. Silodosin, in particular, has a higher likelihood of causing dry ejaculation due to the way it selectively targets certain receptors in the urinary tract. Antidepressants can also play a role, especially selective serotonin reuptake inhibitors like fluoxetine and sertraline. These medications alter neurotransmitter activity and can interfere with the complex coordination required for normal ejaculation. Antipsychotic medications, including drugs such as chlorpromazine, thioridazine, and risperidone, have also been associated with this condition. The second major cause is prostate surgery. This is the most common permanent cause of retrograde ejaculation. Procedures such as transurethral resection of the prostate, often referred to as TURP, can result in retrograde ejaculation in a large percentage of men. During these surgeries, prostate tissue is removed to relieve urinary obstruction. In doing so, the anatomy and function of the bladder neck can be permanently altered. If the structures that normally close during ejaculation are changed, semen may consistently flow backward. Other prostate surgeries, including simple prostatectomy and certain laser procedures, can produce similar outcomes. In these cases, the change is anatomical rather than medication-related, which affects treatment options. The third category involves nerve damage from medical conditions. Diabetes is a major contributor, particularly in men with long-standing or poorly controlled blood sugar levels. Elevated glucose damages nerves throughout the body, including those responsible for controlling the bladder neck. Over time, this nerve damage can disrupt the coordinated muscle contractions necessary for forward ejaculation. Neurological conditions, such as multiple sclerosis and Parkinson's disease, can also interfere with the nerve signals required for proper ejaculation. Spinal cord injuries present another risk factor, with rates of retrograde ejaculation varying depending on the level and severity of the injury. Radiation therapy for prostate or other pelvic cancers is another potential cause. Radiation can damage both nerves and muscular structures around the bladder neck, leading to functional changes similar to those seen after surgery. As you can see, the causes vary widely. Some are reversible, others are permanent, and some depend heavily on overall health management. Identifying which category you fall into is essential before deciding what to do next. And that brings us to the next crucial piece of the puzzle: recognizing the specific symptoms that confirm what you may already suspect. Recognizing the symptoms clearly is essential because once you understand the pattern, you can approach this calmly and logically instead of emotionally. The hallmark symptom of retrograde ejaculation is simple but striking: little to no semen during orgasm. You reach climax. The sensation builds, peaks, and resolves exactly as it always has. Physically, the orgasm feels normal. But when you expect to see semen, there is either a very small amount or nothing at all. In nearly all cases, this dramatic reduction in volume is present. Some men still produce a small amount of fluid, but the volume may be reduced by 80 to 90%. That sudden change can be deeply unsettling, especially if you were not warned it might happen after starting a medication or undergoing a procedure. The second major symptom is cloudy urine after orgasm. This occurs in a large percentage of men with retrograde ejaculation. Because semen is redirected into the bladder, it mixes with urine. The next time you urinate, usually shortly after climax, the urine may appear milky or cloudy. This visual clue is often one of the strongest indicators that semen is traveling backward rather than forward. The third important symptom involves fertility. If you and your partner have been trying to conceive and pregnancy is not occurring despite regular, unprotected intercourse, retrograde ejaculation may be contributing. While it accounts for a relatively small percentage of overall male infertility cases in the general population, it represents a large proportion of infertility among men who specifically have this condition. The reason is straightforward. Sperm must be deposited in the vagina to travel toward the uterus. If they are entering the bladder instead, natural conception becomes extremely difficult. Some men also report difficulty achieving orgasm after they notice the absence of semen. This affects roughly 30 to 40% of patients. The reason is usually psychological rather than physical. The mind plays a powerful role in sexual response. If you begin anticipating disappointment or worry during intimacy, that anxiety can interfere with climax. Reduced sexual satisfaction is another reported effect. Even though the physical sensation remains intact, some men feel that something essential is missing. For decades, ejaculation has been visually associated with masculinity, virility, and completion. When that visual confirmation disappears, it can create an emotional reaction that feels disproportionate but is entirely valid. It is critical to repeat what this condition does not cause. Retrograde ejaculation does not create erectile dysfunction. It does not reduce penile sensitivity. It does not cause pain. The orgasm itself remains physiologically normal. The only change is the direction of semen flow. I once had a patient describe it perfectly. He said, "Everything feels the same. I climax normally, but when nothing comes out, it feels like something is broken." That statement captures the psychological weight of the experience. Physically harmless does not mean emotionally insignificant. Now, let's talk about how we confirm the diagnosis, because assuming without testing can lead to misunderstanding. The diagnostic process is usually straightforward and not invasive. First, your doctor will take a detailed medical history. You will be asked when the dry orgasms began, whether the onset was sudden or gradual, what medications you are taking, whether you have undergone prostate surgery, and whether you have medical conditions such as diabetes or neurological disorders. These details often provide immediate clues. Next comes a physical examination. The genitals are examined to rule out anatomical abnormalities. If you have had prior surgeries, any surgical scars or structural changes are evaluated. The exam itself is typically quick and painless. The most definitive test is called a post-orgasm urinalysis. Here's how it works. You are asked to empty your bladder completely. Then you masturbate to orgasm. Immediately afterward, you provide a urine sample. That sample is sent to the laboratory. If a significant number of sperm are found in the urine, retrograde ejaculation is confirmed. The presence of sperm in the bladder after climax is conclusive evidence that semen is flowing backward. If no sperm are found in the urine, yet you are still experiencing dry orgasms, the situation may be different. In some cases, there may be damage to the prostate or seminal vesicles preventing semen production entirely. This condition is called anejaculation. It is distinct from retrograde ejaculation and requires a different evaluation and treatment plan. I once evaluated a patient who was convinced he had retrograde ejaculation after cancer treatment. However, his post-orgasm urinalysis showed no sperm in the urine. Further testing revealed radiation damage to his seminal vesicles. His body was not producing normal semen volume at all. The distinction changed the entire approach to management. That is why proper testing matters. Once the diagnosis is confirmed, treatment decisions depend entirely on the underlying cause and your personal goals. If medications are responsible, adjustment is often the simplest solution. Switching from one alpha blocker to another type of prostate medication can restore normal ejaculation in many cases. Similarly, adjusting antidepressant therapy under medical supervision may resolve the issue. It is never advisable to stop prescribed medication on your own. but discussing alternatives with your physician is both safe and productive. When nerve damage is contributing, certain medications may help improve bladder neck closure. Drugs such as imipramine, a tricyclic antidepressant, can increase muscle tone at the bladder neck. Decongestants like pseudoephedrine or ephedrine can also tighten the muscle and improve forward semen flow. Midodrine, typically used for low blood pressure, has shown benefit in some patients. These medications are most effective when the nerve damage is partial or mild. They are less effective when anatomy has been permanently altered by surgery. It is also important to understand that these medications can raise blood pressure and heart rate. Men with uncontrolled hypertension or heart disease require careful monitoring before using them. If fertility is your primary concern and medication does not resolve the issue, assisted reproductive techniques provide powerful options. Sperm can be collected from the bladder after ejaculation, processed in a laboratory to isolate healthy sperm, and used in intrauterine insemination. In more complex cases, in vitro fertilization may be recommended. Many men with retrograde ejaculation have successfully fathered children using these approaches. For men who are not trying to conceive, reassurance and education are often the most important interventions. Understanding that the condition is harmless and does not diminish sexual function can reduce anxiety dramatically. I worked with a 62-year-old man who developed retrograde ejaculation after prostate surgery. Fertility was not a concern for him. What troubled him was the psychological shift. Through counseling and open discussion, he gradually reframed his perspective. He realized his erections were strong, his orgasms were satisfying, and his relationship remained intimate. Once he stopped focusing on the absence of semen, his overall sexual confidence returned. Treatment is not one size fits all. It must align with your health status and your priorities. And that leads us into practical strategies you can begin implementing right away to support your sexual health and overall well-being. Let's move into the practical strategies you can begin applying immediately, because even before medications or advanced treatments are considered, there are steps within your control that can make a meaningful difference. The first strategy involves strengthening your pelvic floor muscles. While pelvic floor exercises have not been conclusively proven to reverse retrograde ejaculation, they can improve overall bladder control and enhance muscular coordination in the pelvic region. These muscles play a supporting role in ejaculation, and improving their strength may provide benefit in certain cases. To perform pelvic floor exercises, often called Kegel exercises, start by identifying the correct muscles. These are the same muscles you would use to stop urination midstream. Once identified, contract those muscles and hold the contraction for 3 to 5 seconds, then relax completely for the same amount of time. Aim for 10 to 15 repetitions per session, 3 times per day. Consistency is key. Improvements, if they occur, usually develop gradually over weeks to months. The second strategy focuses on aggressively managing any underlying medical conditions. If diabetes is contributing to nerve damage, blood sugar control becomes absolutely critical. Elevated glucose levels damage small nerves over time, including those that control bladder neck function. Maintaining a hemoglobin, A1C below 7%, monitoring blood sugar regularly, adhering to prescribed medications, and following a structured nutritional plan can slow or sometimes partially reverse nerve dysfunction. If you have a neurological condition such as multiple sclerosis or Parkinson's disease, staying closely connected with your neurologist is essential. Optimizing treatment for the underlying condition may improve nerve signaling and help stabilize symptoms. The third strategy is medication awareness. Keep a complete, updated list of every medication you take, including over-the-counter drugs and supplements. Many men overlook non-prescription decongestants, herbal products, or sleep aids. If dry ejaculation begins shortly after starting a new medication, report it to your physician promptly. The sooner the link is identified, the sooner adjustments can be made. Fourth, communication with your partner cannot be overstated. Sexual health is relational, not isolated. Many men withdraw from intimacy because they feel embarrassed or inadequate after experiencing dry orgasms. This withdrawal can create confusion or emotional distance within a relationship. Open conversation changes that dynamic. When partners understand that retrograde ejaculation does not reduce desire, attraction, or pleasure, anxiety often diminishes on both sides. I recall working with a couple who had quietly struggled for months. The husband felt ashamed and began avoiding intimacy. His wife interpreted his withdrawal as a loss of interest. When we discussed the condition together, she immediately expressed understanding and reassurance. Once the secrecy was removed, their intimacy improved significantly. Fifth, do not underestimate the psychological component. Even when a condition is physically harmless, the emotional response can be powerful. If you notice increasing anxiety, depressive symptoms, or relationship strain related to dry ejaculation, speaking with a mental health professional who specializes in sexual health can be extremely beneficial. Therapy provides tools to manage performance anxiety, reframe expectations, and rebuild confidence. Now let's talk about situations that require prompt medical evaluation. While retrograde ejaculation itself is typically harmless, certain warning signs should never be ignored. If dry orgasms begin suddenly, without any clear explanation, schedule a medical appointment. A sudden change may indicate a new medication effect, nerve issue, or metabolic problem that needs assessment. If you see blood in your urine at any time, seek immediate evaluation. Retrograde ejaculation causes cloudy urine, not bloody urine. Blood may indicate infection, kidney stones, prostate inflammation, or other conditions that require urgent attention. If you experience pain during or after orgasm, that is not characteristic of retrograde ejaculation. Pain suggests possible prostatitis, urinary tract infection, or another inflammatory condition that should be treated. If you and your partner have been attempting pregnancy for a year or more without success, consult a fertility specialist. Early evaluation increases the likelihood of successful intervention. And finally, if the emotional impact feels overwhelming, do not suffer in silence. Quality of life matters. Seeking help is a sign of strength, not weakness. At this point, it is helpful to summarize the core understanding before we continue deeper. Retrograde ejaculation occurs when semen flows backward into the bladder instead of forward out of the penis during orgasm. It affects a small percentage of men overall but is far more common after prostate surgery or with certain medications. It does not interfere with erection or orgasm, and it does not cause pain. Its primary effects involve fertility and psychological well-being. The causes range from medication side effects to surgical changes, nerve damage from diabetes or neurological conditions, radiation therapy, and spinal cord injuries. The defining symptoms are little to no semen during orgasm and cloudy urine afterward. Diagnosis is confirmed through post-orgasm urinalysis. Treatment depends entirely on the underlying cause and your personal goals. Medication adjustments, targeted drugs to strengthen bladder neck closure, assisted reproductive technologies, or reassurance may all play a role. But beyond treatment options, there is something equally important: perspective. Sexual health is more than semen volume. Masculinity is not defined by visible ejaculation. Your body's ability to experience pleasure, maintain intimacy, and function sexually remains intact in most cases of retrograde ejaculation. Still, many men carry silent fears. Some worry that dry ejaculation is a sign of declining virility. Others fear it indicates cancer or permanent damage. Let's address that clearly. Retrograde ejaculation by itself does not cause cancer. It is not life-threatening. It does not spread infection. It does not build up inside you. The semen that enters the bladder is safely expelled during urination. Understanding these facts reduces unnecessary fear. However, we are not finished yet. Because to truly feel confident moving forward, you also need to understand how lifestyle, long-term health decisions, and proactive medical care influence your sexual function over time. And that is exactly where we will continue next.